Hello and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and today my guest is Dr. Patrick Lyden. Thank you so much for joining me today.
Thank you for inviting me, Rosa. I'm happy to be here.
It is such a pleasure to see you again after we met in Phoenix at the International Stroke Conference. And I've been really looking forward to getting to learn more about you and your history because you've been the face of stroke for a long time. We're coming up on 30 years, right?
It's been a long time.
But it would be nice to know kind of more about the man behind the NIH stroke scale because that's what you're most known for, at least among my circles of stroke nurses.
I wish I was known for more of my research, but you're right. The stroke scale is the calling card.
Well, and that's the benefit of being the face of something, right? So you were not the only person working on the NINDS trial that made alteplase like a proven way to reverse stroke, right? How big was your team you were working on?
Well, in fact, I was the youngest person involved in that trial. So there were 7 research medical centers, and then there was a coordinating center, and then there was the NIH running it, or the NINDS. And so all of those centers had senior or mid-career people. I was at the very beginning of my career and barely out of fellowship when that trial started. And so I was the youngest person in the room, trying to not be intimidated by all of these names in stroke at the time and to make a contribution.
So did they make you be the one to be in the videos as because nobody else wanted to do it, or how did that happen?
It's a funny story. So we were focused on the protocol, and we had many meetings in Bethesda. Very, very intense fights. I mean, we really were angry, all of us, about various parts of the protocol. And when you push TPA today and you think, gosh, I wish that blood pressure limit wasn't 185, just remember every single piece of that protocol was fought over tooth and nail, and it took months. And after a while, we got to the point where we were thinking about, how are we going to measure the stroke? How are we going to communicate? And NIH had already piloted a stroke scale. It was based on the Cincinnati stroke scale, and it was adapted for use, and it was used in an NIH-sponsored trial of naloxone. And as I say, there'd been so much fighting that by the time we got to this point, there was a little bit of fatigue factor. And to make things worse, they all knew that I grew up in Southern California. My grandfather was a stuntman in the movies.
Really?
They didn't know, but I have many close friends in the entertainment industry. So when they were looking around the room, they said, well, we need someone to run this video thing. I don't know if I raised my hand or if I got nominated, but I ended up agreeing to sort of kind of co-lead it. And when it got started, when we got the cameras rolling, literally, I unfortunately knew a lot. And I could talk to the camera people, and I could talk to the sound people, and I could say, this is how we need to do it. And I'll just give you one example. All right.
Yeah.
All these video people, they went to film school. They're trained, right? And when you take a picture of someone's face, you frame it like this. And I said, no. You don't understand. We need to see the eyes move to the right and to the left. I don't want to see this. I don't want to see this. I want to see this. Imagine every single item on the stroke scale, every patient. We meticulously crafted the shots. And by the end of that first shoot, they were all looking at me like, there's no one else who's going to do this. You're in charge, kid.
Oh. But it sounds like you were exactly in the right place at the right time. And did you even think you wanted to go into stroke neurology specifically, or what was your career mentality at that time?
So that started, 10 years before that. I graduated from medical school in 1981. And when I was in medical school, we were taught stroke is over in 5 minutes. Stroke is done. The patient is through in 5 minutes. There's nothing that can be done. When I was in medical school, we admitted the stroke patient to the bed farthest from the nurse's station so that they were quiet and no one disturbed them. We minimized vital signs. In some places, there was a caffeine infusion, and in no circumstance did you give the patient oxygen because it was toxic. So that was the sort of the state of things. And in 1981, several papers were published which proved that, in fact, the brain does not die in 5 minutes. That, in fact, after a stroke starts, you have an hour, 2 hours, 6 hours before the brain was completely dead. And so that created this hope that, well, now there's time. And a bunch of us went into stroke research at that time because there was this new hope that if we could find something to do, then we might be able to save at least some of the patient's functions.
And you were right. I'm so glad you were right. But now, so alteplase was used by cardiology first, right? So who did the connecting of those dots to say, well, maybe we could start using it for stroke?
Yeah, so fast forward a few years, I've now completed residency. I'm in San Diego at UCSD, and our department chair was recruiting a doctor named Justin Ziven, and they were recruiting Justin Ziven from back east, and they wanted Justin to come to San Diego, and so they said to him, "We got this resident who's a little batty, and he works really hard, and he'll do whatever you tell him to do. So if you come here, you'll have this minion who will do some work." And Justin did not come because I was there, but he came because he could set up his lab, and he brought this drug called TPA, tissue plasminogen activator. He and Greg Del Zoppo in San Diego and John Marta at NIH connected with Desiree Collin in Europe, who invented or just isolated TPA. They were connected to the cardiologists, and they were working in their labs to prove that it worked. So between 1987 and 1990 or so, I worked in Dr. Ziven's lab, and I learned how to do research, but mostly I learned how to give TPA. And I did a lot of the basic science of giving TPA and learning how to give it, when to give it, how long you give it, and how to make the neurological function improve.
That is amazing. So you started out as his minion with TPA from the beginning. Pretty much.
I did, and then one day he called me into his office. He said, "We just got this grant. We're going to be a clinical trial center, and we're going to study TPA in people." And I said, I didn't say it this way, but I felt like, "Excuse me?" I said, "What are you going to do?" And by the way, I don't know how to do any of that. And he didn't, he didn't care. We're
going to figure it out.
We were picked as one of the 7 study sites in the NINDS trial. And so my job now, by this time, I'm an assistant professor, and I'm supposed to figure out how we're going to recruit patients and enroll patients and give them either TPA or placebo.
And you'd have to enroll them pretty fast if you're going to get them in within 5 minutes, aren't you?
So the first thing I pointed out to my mentor, Dr. Ziven, was that we don't see enough patients at the university hospital to really make a significant contribution. But they're all community hospitals, and I had been, as a resident, very active in organized medicine. I was actually president of the resident physician sections of the AMA, and so I knew all the leaders in the medical establishment. Mm-hmm. So through those connections, I was able to go around to hospitals in San Diego and explain I wanted to be on their medical staff. I wanted to do a trial. There were weeks and months of negotiations and IRB approvals at these 7 hospitals. I got medical staff privileges. But you hit the nail on the head. The trick is to be there quickly, right? The trick is to be there right away. So I had to figure out a way, how am I going to get from home to Sharp Hospital or Scripps Hospital or Encinitas or Chula Vista Hospital. And remember, we had 90 minutes from last known well, not from door. 90 minutes from last known well to get consent, get a CAT scan, get an NIH stroke scale, and enroll the patient and push the drug. So, and the specificity here is a little unclear, but somehow I ended up with a university car that had a siren, alternating high beams, and a little light that went on the roof.
Are you serious? I did not realize that was part of this trial. That is amazing.
When my beeper went off, and by the way, my beeper always had 2 dimes taped on it because the only way to call the hospital was to stop at a payphone and call the hospital and get the details. This was before car phones. This was just before car phones. After the first 6 months of the trial, we did have a big, bulky car phone. Point being, had to run some red lights, had to drive on some freeway, side passes, and take some stupid risks to get in there, get consent, and push TPA within 90 minutes of last known well. And by the end of the study, thanks to all of the work at all those hospitals, we co-led. We were one of the highest recruiting sites in the trial. We were the second leading highest number of patients enrolled in the trial.
What I'm hearing from all this is you know how to hustle. That is incredible. And is stroke something that you were passionate about before, or is it because you got the hope from these other publications that you had this idea that you were really passionate about, or what was your motivation?
I just really wanted to be one of the leaders of the trial. And as I said, I was the youngest person in the room. So how am I going to establish credibility? I'm not smarter than these people. I haven't done research longer than all of them. But what I could do was lead recruitment. So that was my goal. And in fact, throughout the trial, I was the #1 recruiter right up until the last 6 months. Joe Broderick, who is my age and was in the exact same situation under his mentor, Thomas Brott at Cincinnati, Joe was doing exactly the same thing for exactly the same reason. And we were neck and neck all the way through. And he passed me at the finish line and enrolled the highest number of patients. But he was driving around Cincinnati to a large number of hospitals, and Northern Kentucky, same deal, running red lights, trying to get to the hospital and enroll patients. Did he have
one of the little lights
and sirens?
He didn't have a light or a
siren, no.
He didn't, did he? Oh, well. That is incredible, and I'm never going to think about the NINDS trial the same way again. They should make a new show just about that, I feel like. It would be very exciting.
It was very exciting.
So, since you've been the face of it, since you were in the videos, is there somebody that you feel like is the MVP of stroke care that a lot of people just don't know about?
The truth is that, like every big team science project, there's a very large number of people who have to go out of their way, go above and beyond, and make a contribution. So, Jim Grotta in Houston is famous now for the mobile stroke unit, but Jim was doing the same thing in Houston that I was doing in San Diego, trying to motivate his team. They didn't have to go to multiple hospitals. They had a very large hospital. Thomas Brott was the godfather of the stroke scale and of TPA. Steve Levine in New York on Long Island was also sung and doing the same thing. But the two people that had the biggest impact and are least recognized, number one is the nurse coordinator at San Diego, Karen Rapp. So I didn't do any of the car and the running around and the stroke code alone. Karen was right there and co-invented. We thought of this process called code stroke. And the reason we did that is we couldn't get cooperation from CAT scan, from lab, from EKG. So we turned it into a code. The code trauma, everybody drops what they're doing, right? So we said, well, let's call it code stroke. and on and on. The mechanics that you now take for granted in a code stroke, Karen really thought up a lot of that. The most unsung person behind all of this is John Marler. John was at NIH, at NINDS, and he was the project leader. He wrote the protocol. He's the one that insisted we had to do this within 0 to 90 minutes. And I was rude and vociferous. John, this is a mistake. We can't do it. No one can treat stroke that fast. And he said, you have to. And in the end, he was right, because that's why the study worked. We got TPA in early. John led the trial when we were concerned, we were hurting people and not helping. He motivated everybody. He kept getting more money when the study had to be doubled in size, and made all of these incredible decisions that were very unpopular in real time. But it was his vision to test TPA in patients, to take it from the lab where Justin Zivit and Greg Del Zoppo were testing it and take it to people. So John Marler really is the MVP of the story of thrombolysis. That's for sure.
Wow. Do you say his name is John Marley?
Marler. Marler.
Marler. Okay.
Yeah.
Wow. That is incredible. I'm really glad I asked you, because I need to look these people up now.
Yep.
And do you still work with any of them on like your national work with like the American Heart Association or anything like that?
So John is retired and enjoying his retirement. Dr. Zivit unfortunately passed away. I still see some of the NINDS studies folks at annual meetings once in a while. We had a mini reunion, those of us that are still going to meetings, and got a picture together a few years ago. But we're all getting to that age.
Wow, that is amazing. It would really be the OG crew, though. These are the originals.
Yes.
Yeah, that would be amazing. So, nowadays, we around 30 years later, we've seen a lot of other developments, not just alteplase. Now we're using TNK or tenecteplase, which you can push faster than alteplase. We have neurosurgical interventions like endovascular mechanical thrombectomy, where they can pull a clot out of someone's brain blood vessels and revascularize that brain tissue. And we've seen the time window expand from the 90 minutes for endovascular procedures up to 24 hours. And you've got some new trials you're working on now, right? What's the next big thing that you're looking at for stroke care?
Well, before looking ahead, it's important to look backwards to learn a lesson or two. And the first thing is, remember I said I did some TPA work in the lab, and then I worked on the clinical trial, and it worked. And we had a publication in the New England Journal. I thought that's just how it goes. You do a little bit of lab work, you work for a couple of years in the clinical trial, you have a new drug. And as you say, it's been 30 years, and we don't have another drug. We do have endovascular thrombectomy, thank goodness. And we do have advanced imaging, thank goodness. So we don't have to depend on the clock anymore, or the 90-minute or the 3-hour do or die time frame. We can do advanced imaging and select patients. But when we select, we're selecting a minority of patients. We're not treating everybody. There's only a handful of patients relative to the problem. And, stroke is the most common cause of disability in the world.
That's
More
right.
people are disabled due to stroke than any other cause. More women die of stroke than die of breast cancer. More
or
children.
All cancers combined, right?
I don't know if I'd go that far, but certainly you probably know better than me.
Well, I think the American Heart Association likes to say that cardiovascular disease kills more women than all forms of cancer combined. So
cardiovascular, when you include heart attack, absolutely true. Absolutely true. More children have stroke than pediatric leukemia or pediatric brain tumors. So we're struggling with an incredibly common cause of disability. We have one treatment that works that not everybody can get. And we have two treatments, when you combine thrombectomy, that a few people can get, but it doesn't work all the time. So the lesson is we can't rest on our laurels. And the other lesson is we have to be very, very John Muir about how we go forward. There's no shortcut. There's no easy pathway. I've been involved in a lot of clinical trials where the sponsor was afraid to impose these limits and say, your drug only works within 4 hours, but we're going to give it up to 24 hours because we're afraid we won't recruit enough patients. So the lesson is stick to your guns, do the trial the right way, don't cut corners. And we're finally starting to do that. So, for example, in the preclinical world, for many, many generations of new drugs, we have said, okay, this new drug, it kind of works in one mouse study. Let's go ahead with a clinical trial. But that mouse study wasn't blinded and it wasn't randomized. So we finally started, and I lead a project where we have 6 laboratories that we study new drugs with absolute rigor, top-notch, every scientific rule that you can imagine to get a high-quality study. On the clinical trial side, StrokeNet is beginning to roll out clinical trials that are based on the science, not on the convenience. How do you give the drug in the best way to get a true result and make the patient better? And that involves earlier. So when you ask me what's the next big thing, it is going to be a focus on cerebral protection, making the whole brain better, and using treatments that either work best when combined with TPA or work without TPA, because that's the bigger unmet need.
Yeah, and brain health is important for everybody. A lot of people don't care about stroke until after they have one or know someone who's had one. But like you said, it is the leading cause of disability in the world and a big cause of death in the United States as well. So if we take the steps to prevent stroke through the modifiable risk factors we can, such as preventing obesity, high cholesterol, high blood pressure, diabetes, we can actually make a huge impact in decreasing the amount of stroke that way as well, which, might give you less patients to work with for your trial, but that wouldn't be a bad reason to have less patients, would it?
None of us in stroke are ever going to have to worry about being unemployed. Even with risk factor management, there is still going to be, unfortunately, a high number of heart attacks and stroke. It's just part of aging, part of being alive, that these things do happen. So I would love to see, stroke rates cut in half. And yet we would still have plenty of work to do.
Definitely. And one important thing we can do is let people know to come to the hospital when they're showing new signs of a stroke. So we have acronyms that we use that we've publicized to let people know if you see any of these new signs of stroke, call 911 and get to the emergency room as soon as possible. And I think you and I were talking earlier about like season 1 or 2 of ER. They were having an argument about what to do with a patient. Should they give them this scary new medicine all to place? And they were like, well, if you were on the code team, then you would know.
Right.
And it's a lot more standard to get these interventions when you get to the hospital now, and it's not so much of an argument. But it is key for the community, anybody, whether they work in medicine and healthcare or not, to recognize the signs of a stroke. And like when I, as a stroke navigator, call patients, a lot of times they'll know the symptoms they came in with, but maybe not other new ones that they would need to watch for. So I'll use the acronym B FAST, where B is for balance, E is for eyes, to have a sudden change in vision, F is for face, like a facial droop on one side, A is for arms, where one arm is weaker than the other, S is for speech, like slurred speech, and T is for time, where time saved is brain saved, as you have proven. But so far, the American Heart Association only puts out the acronym FAST and doesn't
Mhm.
include balance and eyes. And so, since like 65% of people who experience stroke have their vision affected by stroke, do you think that there's any chance those will get added in the future?
It's a really good question, Rosa, and thank you for pushing it and raising the question. And I think BFAST is preferred in many sites. You know, when I make site visits and visit a stroke team, I often see BFAST on the wall rather than FAST. So to that extent, it doesn't matter what American Heart does, but it would be better if American Heart endorsed it. And um, the I think if enough of us professional volunteers lobby and push and ask that American Heart change their policy, they will. But you know, they've invested a lot of time and money in creating an educational campaign that works with
Mm-hmm.
the one way of talking about it. You know, we're all trying to solve the same problem,
Yeah.
which is that stroke can do many different things. I was I'm old enough to remember the heart attack campaigns from the 60s and 70s when coronary care units were first invented. It was not easy to tell people crushing chest pain, nausea, and left arm pain, go to the hospital. But it worked because it was simple. All heart attacks,
Mm-hmm.
that's what they do, and you could communicate that, and it was not only American Heart, but you know all the cardiology organizations at the time succeeded because the message was simple.
Mm-hmm.
But now we might have a brainstem stroke and have some imbalance. We might have a left MCA stroke and not be able to talk. We might have a right MCA stroke and be stumbling on one side. How do you create an awareness campaign with simple messages? And it's very challenging. It's very difficult. All of these acronyms and ad campaigns help. It all helps.
Mm-hmm.
But the mountain we're trying to climb is very tall.
Yeah, definitely. And lucky for stroke, they have people like you and me who are not afraid of being on camera and getting some more messages out, right?
Absolutely. I will tell you every time I have an interview like this, although I've never been on a podcast before, so forgive
Oh,
me, but
well, welcome to
um,
your first podcast interview.
thank you. But every time there's any mention in the press, you know, activity at the local hospitals or nationwide, if it's a nationwide case, goes up. And for a few months, we get a few more cases. People will say, "Yeah, I saw this thing, and I just wanted to get it checked out." So every time we do something like this, it helps. So
Mm-hmm.
thank you for doing it because
Mm-hmm.
it's really you and people like you that are between the profession and the public trying to make that connection and trying to
Mm-hmm.
simplify the message and get it out there. And it really does make a difference.
Exactly. And you and I can talk about TikTok strategies later since you and I already have an established partnership there. we
I'd
made
love
a
to.
Yeah, we made a funny video. Feel free to check that out on Nurse Rosa Speaks on TikTok if you like. But I need to ask you the $1 billion question that every special guest on this podcast gets. And I know you're used to working with grants in the millions of dollars. But if you were given a grant for $1 billion and you got the honor of choosing how it was used to transform healthcare, make it better, or meet the needs that you see, and it may not even be stroke related. I kind of suspect it might be. But if you could use $1 billion grant to make transformational change, how would you like to use it?
Um, think about how the world was before we had thrombolysis versus after. Before thrombolysis, we took good care of stroke patients. As I say, we admitted them very far from the nurse's station. We gave them a little bit of caffeine and didn't bother them too much. Along comes thrombolysis. And now the whole world is different in stroke because of one person, Desiree Collin, isolating an enzyme and showing that you could open arteries with it. So, what's the equivalent game changer nowadays? What has to be different? We've spent 30 years looking for neuroprotectants, right? Drugs that protect neurons. And we give those to stroke patients and nothing happens. It doesn't work. So, what we have to do with $1 billion is answer the question, what does it take to save the brain? We have a theory in my lab that what we have to do is protect neurons and astrocytes and blood vessels. And to do that, take advantage of the brain's own healing mechanisms. The brain has a way of protecting itself. I would invest $1 billion in exploring those mechanisms and ask, if the brain evolved to do it this way, how do we enhance that? How do we make that better? How do we take advantage of what the brain is already up to during a stroke or head trauma or cardiac arrest with encephalopathy or hepatic encephalopathy? You could look at all brain insults holistically and say, what is it that the brain does that we can then mimic and make better? Instead of looking for chemicals that in the lab make the neurons better, let's look at the whole brain. And it would take $1 billion. we are behind the 8 ball here because very few, not zero, but very few of us are actually thinking along these lines. And I am absolutely certain. I'm absolutely certain that after $1 billion, we would find those mechanisms and we would find ways of enhancing those mechanisms, which would help patients who don't get to the hospital in time for TPA or don't get all the way better after their thrombectomy.
Well, yeah, and that does go way beyond stroke too, because like as you mentioned, different forms of encephalopathy that happen from brain insults due to things that are not just a lack of circulation. So
Exactly.
yeah, that would be incredible. I would love to see that happen. And one of my dreams for the Nurse Rosa's Insights podcast is that someone who has $1 billion and is looking for a productive way to give it away can find a good direction to send it. So maybe they'll hear you.
Lyden@usc.edu. We're open 24 hours.
That's fantastic. May or may not come running with a siren on his car.
Yeah, I don't do siren anymore. I don't run red lights anymore.
Yeah.
I've grown up.
Good.
I'm not that young. I'm not the youngest guy in the room anymore.
Well, that's okay. I still respect your hustle, and I'm so grateful that you took the time to share your story, as well as, give some context and give some shout outs to the other people who made this incredible transformation happen in stroke care and give so many people hope that wasn't there before.
Good to be here, Rosa. Thank you for inviting me. I'm very honored to join your pantheon.
That's fantastic. And so, as you heard his email address, I'll have it listed in the show notes. So, if you would like to reach out to sponsor this wonderful work, feel free to email him there. And follow the Nurse Rosa's Insights podcast on your platform of choice. It is on video on YouTube as well as on all audio platforms through the Health Podcast Network. And I'm on social media at Nurse Rosa Speaks on all those platforms. So check me out there, and I'll see you in the next episode.